Well, thank you very much for that introduction, and thank you for the invitation to be here with you this afternoon. It's an honor and a pleasure to be here in Pune. I had the opportunity to visit last year. That was my first introduction to India, and met some wonderful people here, and see a lot of familiar faces already. So thank you again for the invitation. So what we're going to do in this talk is perhaps look back a little bit before the rest of the talks look forward, and talk a little bit more about just the conventional knee arthroplasty, focusing mostly on total knees, and asking the question, what is lacking? Okay. So my disclosure. So to break this agenda down a little bit, this is how I'll approach it today. Just go from basic on through to a little bit more of the technical nuances that we like to focus on in arthroplasty. So simply put, what are the goals of total knee arthroplasty? Okay. Sometimes we need to just take a step back and look at that. So I would say we need to break these goals up, because what we as surgeons have as goals is perhaps not exactly what our patients have in mind in their goal for their knee replacement. So let's see if this pointer works here. Maybe. Yeah, there it is. So maybe the light's too bright up here, but you guys can see these would be my goals for a patient. To achieve natural knee motion and function, improve the accuracy of the surgery that we do, ultimately leading to better clinical outcomes and long-term survivorship, to do it in a safe way but also efficient. Many of us are very busy in our operating rooms and theaters, and time is truly of the essence. And if new technology increases our OR time dramatically, that's going to be a steep learning curve for surgeons to climb. So we need to look at that. What does that really look like with this new technology? Patient goals, again, they're looking for pain relief from their arthritis pain. They want improved physical function. They want their new knee to be durable. They would prefer to do one and done, as we say in my office, one surgery that lasts them the rest of their life. They also want a safe surgery, minimize the risks associated with it, reduce the risk of complications. And more, patients are coming in with questions. You know, they're what I refer to as their Google MD degree, where they come in with a stack of paper, sometimes an inch thick, with all these questions that either they or their son or daughter-in-law have come up with based on their internet research. So patients are becoming much more savvy in terms of knowing about our business. And I think that's good, because it engages them in the conversation. And if they do have specific questions about an implant or technique or pain management protocol that we follow, we discuss that with them. So let's look at conventional knee arthroplasty. And again, I don't want this talk to be a talk looking at our predecessors and the forerunners of arthroplasty and say, boy, wow, I can't believe that they did that 30 years ago. But we'll try to look at it in an educational way is what I'd like to do. So if we start with the preoperative planning stage, we're all familiar with, our X-rays, the old printed type or the PACS digital imaging nowadays, where we would do preoperative planning. And with my mentors, we spent a lot of time with preoperative planning, talking through the operation as a resident, intern, fellow, and discussing how we were going to handle each case. And we do that typically a week ahead of time. And nowadays, that's shifting. We're still doing preoperative planning, but we're doing a lot more of the planning in real time. But again, we're talking about conventional here. So intraoperative measurements and surgical judgments are on us, as I like to say, okay? So that's us right there, right? And some people would say that orthopedic surgeons are glorified carpenters. I think most of us would beg to differ to some degree, but we are using our brains, our eyes, and our hands to execute our surgical plan. Our brains are our own computer, and our hands are the robots, if you will, with our instruments, okay? That's in the conventional setting. And then we're using standardized instrumentation to prepare the knee based on subjective assessments and measurements. It really focuses on what I refer to as the static anatomy, which is the bones working between the soft tissues and following the standard protocols that we were taught and are outlined in all our technique manuals and books that we read back in the day. And I say it ignores dynamic anatomy. I don't mean that completely. It means that we focus on the bones first, right? We do the preoperative planning, what size, what orientation is this component going to be in, and then we go to the soft tissues after we've done our bone work, right? So on the right here, you see an algorithm that I pulled out of one of my textbooks from about 25 years ago, and the column in the middle there is all the different bone steps, and at the end it says balance soft tissues, and then you're done. Okay. So it was almost an afterthought. You do all the bone work first, and then the soft tissues, we'll just take care of that later. But again, that's a subjective balancing of the knee after the static structures have been addressed. Let's see here, going forward. Make sure. I think we have a little lockjaw going on here. Here we go. So any measurement system which defines the accuracy and precision of what we actually do in the operating room is determined by what I call the OCD level of the surgeon, how thorough we are and how much experience we've gained over the years as the primary surgeon. And that's, I think, for those of us that were trained well, who had excellent mentors who taught us the technique of this surgery, that works well. But not everybody has that benefit, and we recognize that. So to quote President of the United States from a number of years ago, and I share this with a lot of people, it says, rely on planning, but never trust your plans. In other words, be adaptable, be malleable, and be ready to change if you feel like you need to do that. And change can come in many different forms, obviously. So to ask the question, with this conventional surgery approach, are we meeting the goals of total knee replacement? And we just saw some of these similar slides just a few minutes ago, in that this percentage of 20% of dissatisfaction is very real, and it's across the globe. It's not just in the United States or Canada or Europe or Australia or here in India. It's everywhere. About 1 in 5, 1 in 6 of our patients are just not happy with their outcomes. And this is a great quote just from Journal of Arthroplasty last year, Barron's, who's in Indiana, that identifying patients who may be dissatisfied and understanding the cause is mystifying. So basically, he's just throwing up his hands and saying, I don't know why these patients aren't happy. I'm doing the best I can. And the reality is that maybe he is, maybe we all are, but I think we can do better for our patients and do what I call bending the curve of dissatisfaction. All right. What can we do to address that 1 out of 5, 1 out of 6 patient who's not really happy with the knee that we did? That might be the case that we look at the x-ray, we say, looks good, patient says they feel bad. That's not a great case to be sitting in front of and trying to have that conversation with the patient. So what impacts the results of our knee arthroplasty techniques? And I would break it down into these 6 categories and then break it down a little bit further and say the first 3 are really on the patient and the last 3 are on us, the decisions that we're making. So for the purpose of this talk, we're just going to lift up those 3 that are on our shoulders and focus on just briefly surgeon experience, talk about the surgical technique and the accuracy of that. Component design, that's a whole nother talk. I'm not going to get into that. We can talk about that for the rest of the afternoon and all day tomorrow. So we'll leave that be for the time being. So surgeon experience, again, it's simple. You do more cases, you're going to have more experience under your belt, and hopefully for the cases that you do in the future, you'll do better for those patients. All right, and that's a very good protocol to follow. Unfortunately, there are going to be patients who are on that early side of our learning curve, and that's maybe not completely fair to them. So let's look at the surgical technique. And as was pointed out, and there's going to be I think a lot of overlap in our talks this weekend, because we all feel the same way about our patients, our surgeries, and where things can be molded and adapted. Because our operation is truly both a bone procedure and a soft tissue procedure at the same time. So if we just focus on the bone preparation, There have been certainly valiant measures to standardize this procedure as far as our instrumentation, and the engineers and the companies have really done well over the years to make the instrumentation slicker and smoother and more user-friendly, more adaptable, that allows us to shift and adjust cutting blocks and things like that, but we're still using cutting blocks. But we really are in the process working to shift from subjective to objective. These instrumentation changes have allowed us to standardize, to minimize steps, make things more reproducible, perhaps have fewer trays on the back table, to ultimately, and the buzzwords are to get the accuracy and precision raised as far as how we're putting the components in. What about the soft tissue technique? I think we're all familiar with this 9-segment array of how do we manage a knee from a soft tissue standpoint. If it's tighten, extension, and well-balanced inflection, what's the adjustment that we do from a technique standpoint? And we go through our different algorithms depending on which box we find ourselves in to try to balance the knee. Okay. And there's been quite a bit of research, and there are a multitude of papers that you can read about that advise us on how to do the soft tissue releases. My question is, do we really need to do all those soft tissue releases that I was taught to do when I was in my training? And I think the answer, it's a loaded question. The answer is probably not in a lot of cases. So again, here's just one example of where we put our osteotomes or where we put our elevators to do soft tissue releases. And these are good techniques to know, but if we don't have to do them, that's less trauma to the patient's knee. As was mentioned as well, the stability assessments, we focus on 0 and 90 degrees, but that's not where the patient lives. The patient lives in mid-flexion, 15 to 75 degrees. And they want a knee to be stable in mid-flexion. They don't know that, but functionally they know that because that's when the knee feels good, when the mid-flexion balance is achieved. So there was a very nice article that came out, I think in either this month's or last month's Journal of Orthoplasty. There was some excellent articles. If you guys if you haven't looked at Journal of Orthoplasty, talking about robotics, cast stuff, excellent articles, really very, very good topics. But instability is one of the most common reasons for revision surgery, and so our goal should be mid-flexion balance, not looking at it from the other side as mid-flexion instability. So this is a quote I think that most of us heard somewhere along the way. Knee balancing remains an art, and it's subjective feel that we do through our hands. Interestingly, this was in an article that just came out this month. A surgeon still saying this, same as my mentors taught me 25 years ago. And I think we can move beyond this. The art means it's subjective, it's not objective. Let's make it more objective. So as far as soft tissue techniques, I don't really see a whole lot has changed in the course of my 20 years in practice. And why is that? Maybe it was because we didn't have anything else to substitute with it like we do now. Who knows? So if we look at new technology, the list is there. Lots of different things have come. A lot of them have gone after they were tried, and the research really didn't show significant improvement. So let's break this down a little bit. And I would break it down into these 3 categories. CAS, the newer handheld sensiometers, and the patient-specific instrumentation in 1, the kinetic sensors in the 2nd, and then robotic-assisted in the 3rd group. So if you look at the first group, really what this is addressing the bone technique that we just talked about. It's looking at component position and limb alignment. So in other words, focusing on the static structures like we would with measured resection technique. And yet, for the most part, and I'm not trying to stereotype every system here, but for the most part, it's ignoring the soft tissue balance. The intraoperative sensors, OrthoSensor and iAssist, there's a few more of them, are working on soft tissue balance. In other words, they're working on the dynamic side of things as we would with gap balancing technique, but yet they completely ignore component position and alignment. So they're working in these 2 separate bubbles here, and we're working in the middle trying to get a little bit of this and a little bit of that. And so you can hybridize by using CAS and then throwing an OrthoSensor in, and that might work in your OR. So what are the results? And we just saw some of it earlier as far as CAS, that it's certainly helped and it's been around for over 20 years, as was pointed out, it really has helped with the accuracy of bone resection and to reduce the risk of outliers. And theoretically, that if you do that, you do your bone preparation well, you'll get a more symmetric joint with more balanced soft tissues. But the statistically significant improvement has not really been demonstrated. Maybe some of the longer-term results that we're just starting to see will change our mind a little bit, but the intermediate, medium-term results really didn't show that. This was a nice literature review out of Advances in Orthopaedics, and there's 20 publications on the left under the no column that has CAS improved over conventional total knee replacement, and only 2 on the yes side. That's a pretty easy decision to make in my mind. PSI, designed to increase efficiency, cutting accuracy, truncation of steps, in other words, shortening the operation, making it a little bit more efficient. It certainly has done that, but unfortunately it has actually increased the statistical incidence of outliers, which really we don't want. We're trying to reduce the outliers. And in about 1/4 of cases that the cutting jigs had a coronal error of in excess of 3 degrees, which in my OR is not acceptable. So again, something that has had a lot of promise when it first showed up. The studies really aren't corroborating that. Cochrane review, very thorough review, again, did not demonstrate improved limb alignment or component alignment compared to our standard instrumentation. So again, new technology that really didn't pass the mustard, as we say in the States. So this is, again, kinetic sensors. I think you guys are all familiar with that. And there is some positive results coming out looking at things like OrthoSensor. This was a study that Jimmy Chow, one of my colleagues in Phoenix, published last year, that at their 6 months, patient-reported outcome scores and range of motion was better in their OrthoSensor cohort. And similarly, manipulation under anesthesia rates in this study dropped from 5% with standard instrumentation to 1.6 with the use of OrthoSensor. So that to me is encouraging, okay? And that to me also emphasizes that this is more of a soft tissue operation than a bone operation. So another study showing positive improvements. So conclusions, the technology that addresses the dynamic is doing well to help us. That which is just focusing on the static is perhaps not as good. So if we look at this question that was posed to me to present to you guys this afternoon, what's lacking, I would flip it around, is that what would the future hold if we could design our perfect knee, the technique and the implants, etc. So I would want a proactive approach instead of a retroactive approach. I consider, working on the bones and then doing my soft tissue releases, that's retroactive or reactive as opposed to proactive. I want accurate input, not garbage in, garbage out. And that includes both an assessment preoperatively, whether it be on a CT-based image or a surface mapping image where there's a soft tissue and bone assessment that's been done in real time. And then the optimal output, meaning that we've done well as far as component position, limb alignment, soft tissue balance, all under our control, okay? Because we're surgeons. We're taught to be in control, and we need that in our operating room theaters. So in my book, the ideal knee replacement system, as I see it right now in 2018, is a hybrid of the 2 techniques, measured resection, gap balancing, that's a proactive and not a reactive system. So it might look something like this. Who knows? Because we know that my cell phone certainly doesn't look the same this year as it did 3 years ago or 5 years ago or 10 years ago. And so what we're going to be looking at here 2 years from now or 5 or 10 years from now will probably be radically different, but hopefully that will be to the betterment of our patients. Thank you very much.